Good afternoon, all, and warm welcome to today's session. I am Arpita, your moderator from the IGCP group. It's pleasure to introduce our esteemed speaker, Professor Dr. Sunil Kumar Agarwala, sir. He is MBBS, MD, serves as a professor at the Department of Pediatrics at Sardar Vallabhbhai Patel Postgraduate Institute of Pediatrics, Cuttack. Today he will be sharing his expertise on case-based learning, unlocking better diagnosis through detailed examination. This session will provide valuable insights into how a structured and thorough approach to patient evaluation can lead to more accurate diagnosis and improve clinical outcomes. So, with this introduction, sir, now I would request you to please start with the topic for today. Over to you, sir.
So thank you, Arpita, for the kind introduction, and thanks to Ankana as well, and total team of IJCP for this wonderful connect between the doctors of India. And now there was a special request from your team that this time this webinar will be discussed on a case-based learning so that our doctors will be maximally benefited. So thanks for this novel idea, and we'll be starting a case straight away. Before that, very good afternoon to dear doctors. I must thank all of you in spite of your busy schedule. You have already logged in for the knowledge interaction and knowledge gain. So let's start from a case discussion. I'll tell you about the real case scenario. A 6-year-old male child, history of fever for 10 days. You look at this child, fever for 10 days, mild cough was there, vomiting was there, and there were maculopapular rashes all over the body swelling. You see the periorbital puffiness is there, and body is swollen up, irritability and drowsiness since 3 days. Child was seen by 2 doctors and received amoxicillin for 4 days. 4 days, ACT for 3 days, and paracetamol. So this has been given treatment that is outside. Hospitalized at another hospital 2 days and treatment with IV fluids and ceftriaxone. So what we got, this is a fever of unknown etiology, or you can say this is a short duration of fever without any localizing sign. Now, New Nelson and new book, they say about the fever etiology, if it is not being localized to any part, that is known as fever without localizing sign. And this belongs to fever with localizing sign, but there is irritability and drowsiness. So that's why somehow we can think of neuroinfection. So with this, what is the neuroinfection? Where you get rash, fever with rash, and there is altered sensorium and irritability. Let's see. So till now, differential diagnosis: 10 days fever, fever with rash and loss of sensorium or consciousness. One of the diagnoses will be AES because this is viral in etiology, and acute encephalitis syndrome. Now, some of you can say because fever is there, rash is there, and it could be dengue. Why I have cut this? Because the dengue, a complication of whatever you see, this type of neurological manifestation of dengue is first of all rare, and usually you see dengue is a infection of 3 plus 3 plus 3. That means 3 days viremia, 3 days complication, and 3 days convalescence. So this is a 10 days fever, still the child is unconscious, unlikely to be dengue. Now, could it be bacterial meningitis? Yes, there are a couple of bacteria, they can cause rash, or due to cytokine storm, you can see rash. So meningitis could be a possibility. Then, though malaria has gone down in the list, but still then the child came from the malaria endemic zone. In 2025 also, we can bring the diagnosis of cerebral malaria. And that's the reason you have seen that this particular child has got ACT, artemisinin-based combination therapy, that is artemether and lumefantrine by periphery doctor, and 3 days. So that's the reason. Could it be cerebral malaria? And finally, scrub encephalopathy. What is this scrub? Scrub is a pattern, is a part or is a subset of rickettsial fever. And if that occurs to the brain, we tell scrub encephalopathy. So these are the 5 diseases we are bringing. So now let's see on examination what is happening. Child is febrile. There is no lymph nodes palpable. Some pallor is there. No icterus, throat normal. Rashes are present. Eyes are normal. Heart rate 120 because the fever is there. Respiratory rate 30 without any chest sign. Blood pressure 90/60 in a child who age of 6-year-old we can accept this as a normal. Then comes your saturation in the room air is 94. Systemic examination, respiratory system, cardiovascular system, no finding detected, and there is liver and spleen palpable, hepatosplenomegaly. Now I will tell you, if you see some pallor hepatosplenomegaly, then always remember it may not be AES, it may not be meningitis, it could be a pre-existing hemolytic anemia presenting with neuroinfection. That could be a possibility. So that's the reason we digged into the past history. We never got the past history of sickle cell or thalassemia in this child. So this hepatosplenomegaly is of recent etiology, and this fever causing altered sensorium, the same fever is causing hepatosplenomegaly. The child is drowsy, irritable, and there are no meningeal signs. Now narrow down differential diagnosis. We can put the diagnosis that it could be viral encephalitis. But remember, if there are rashes, the J is ruled out. Remember, dear doctors, if any point of time you get rash, then that is not the feature of J. So it's not J, it is a non-J viruses, like you can say enteroviruses or some other viruses can give rise to AES. Now, cerebral malaria, still we have not excluded. And the third possibility is the scrub encephalopathy. Now, if I tell these three, if there is some pallor and hepatosplenomegaly, then there is no history of pre-existing hemolytic anemia. One will be saying, could it be cerebral malaria or could it be scrub encephalopathy? And that's the reason we started empirical therapy with a cocktail of ceftriaxone, acyclovir, and because we know that investigation wise ICT came out to be negative and MP negative, we have started with artesunate, but that has been stopped, and we are yet to get the scrub report. And finally, we have also started doxy. So in total, the child is getting, one is ceftriaxone, another is acyclovir, another is doxycycline. 3 as a cocktail we have started. Now let's see. Investigation hemoglobin is 9.2, TLC 14,500, neutrophil 68, and platelet is on the lower side. Always remember, if you get a thrombocytopenia, then there are 3 diseases. One is dengue, another is your any viral infection, but another is scrub, another is malaria. So let's see, SGPT and SGOT are being increased. That is known as transaminitis. Total serum bilirubin is only 1. CRP is 7. 6 is the cut point. ICT for malaria is negative. That's why we have stopped artesunate. Serum creatinine is 1.2. That is little bit elevated. Dengue serology came to be negative. Serum protein, albumin is low and total is normal and globulin is this. Typhoid test, which is IgM for enteric fever. Sometimes we can get a complication of typhoid fever towards the second week because it was the 10 days, though we are not keeping hepatosplenomegaly so common in enteric, so that's why still we have not put as a DD, but investigation we have done. Urine routine came out to be this. So what I am saying here, IgM scrub came to be positive. Now the final diagnosis we can tell that this particular child who came with fever, rash, altered sensorium, hepatosplenomegaly, pallor and thrombocytopenia came out to be scrub. What we have done then? Final diagnosis, scrub encephalopathy. We have put 5 DD. Now one after another, dengue gone, then AES gone, then we have left with 3, meningitis, unlikely meningitis in hepatosplenomegaly, that gone, left with malaria or scrub. Now malaria gone because ICT negative, MP negative. Now we have left out with scrub and it came out to be IgM scrub positive. Now we have re-examined the child from top to bottom and we have not opened the genitalia because there was pampas, and that's the reason you see there is a nice SCHAR is there. This SCHAR at right inguinal jaw we missed on the day 1, 2, 3 of hospitalization. So dear doctors, having said that, if this child would have been examined, open thoroughly, we could have got this SCHAR. So the message is that if you examine the child from top to bottom, very detailed examination, and in a child who come to us with altered sensorium, and definitely if you get a SCHAR like this, cigarette burn like SCHAR, then the diagnosis then and there, and it is a case of scrub encephalopathy, that you need not to add acyclovir, or you can say there is no need to add artesunate IV, but but straight away we can give doxycycline and we can save the life. So the message from here is that the treatment which the child has given, IV fluids, IV safety action, because concomitant bacteremia, we have started this, and IV doxy after 2 to 3 days the child became all right, conscious, taking orally. GCS became 15 by 15, and we have switched over to oral doxy 2.2 mg per kg BD, and no steroids are being given. So, dear friends, eyes are useless when the mind is blind. If the mind doesn't know, eyes cannot see. And that's the take from this case, that the investigation came to be IgM scab positive, and thereafter we searched this child from top to bottom, opening and exploration, that we found a SCHAR. Why not? This idea was not there in our brain. Since then, to all my postgraduates, it's a dictum that if a child come to undifferentiated fever or a fever without focus, then definitely we have to see if there are pallor or icterus or lymphadenopathy and hepatosplenomegaly. One has to search for SCHAR in the hidden area. And the common site may be post-auricular, maybe in the armpit, maybe in the genitalia. These are the common areas. However, any place is not a bar. Any part of the body we can see SCHAR. So learning point: fever, rash, loss of sensorium, pallor with hepatosplenomegaly, SCHAR present, scab type. You see at the time of discharge on day 5, the child is sitting, eating, conscious, and that gives a very satisfying thing, that if a child comes like this, scrub encephalopathy, we can diagnose on day 1 by searching for SCHAR. It doesn't mean that if you do not get SCHAR, it is not scrub. I'm not talking on that. But still then, if you get, you are a lucky doctor. So there is a probability of 9% to 52%. That means every alternate or every third or every fourth patient, you may get a SCHAR. So if you do not get, that doesn't mean that you will not investigate or you will not start doxy. On a saving point of view, we have to start doxy on the day 1, and we can mobilize our protocol of management once the investigations are ready. So I'll show you a couple of pictures of SCHAR. Now case 2, you see there is another SCHAR. You see how beautifully it is being there just beneath this scrotum. Why? I'll tell you. This is a Chiger-borne disease. Now Chiger is the larval form of mite, trombiculate mite. Now this mite bite, or the Chiger is the larval form of the bite. They bite at the hidden area, and our accessibility by the hand and taking out them is not good. Sometimes you can get SCHAR which is beneath this waistband. So this is another, and you see how just I was talking of a waistband, and beneath the waistband the SCHAR was there. If you do not examine properly, if your mind doesn't know, you may not pick up this SCHAR. Now you see there is a ulcerative SCHAR, as if it is a cigarette burn like SCHAR in the neck, and that says that this is a case of scrub. Not all cases will come as CNS manifestation, but few of them can present to us with myocarditis. Some of them can present to us with severe anemia. Some of them can present to us as hepatopathy or MODS. You see there is another SCHAR in the armpit, right armpit. And this is the genitalia on the right side. You are able to see there is a SCHAR. And this type of SCHAR, if you see, and one SCHAR, this is one of my postgraduate found out on the day 1. After that, all the postgraduates, those who are working under us, they are very good in searching SCHAR on the day 1. If they are getting, usually we are promoting and we are just stimulating them that it is a good news that they can pick up on the day 1. If they failed, then my senior resident, they will search. If everybody failed, then definitely I am there to find out this type of SCHAR is there or not. What is this SCHAR? At the initial site of mite attachment, the adult mite doesn't attach. It is the larval form of the mite. The place where it attaches and releases the cocobacilli into the skin, that is the site of point of entry of cocobacilli. So what is rickettsia? Rickettsia are nothing but are bacteria. They are neither coccus, they are not bacillus. In between them, so they are known as proteobacteria. They are the cocobacilli. So the site of attachment, there occurs a inflammation, ulcer, and that ulcer at the site of entry sometimes healed up, and it is not seen when the child presents, and the incubation period is on an average 10 to 14 days or 7 to 10 days like that. So specific features: single painless SCHAR. This SCHAR is painless, but that SCHAR is drained into the node. That is a painful node. So this ulcer surrounded by a red areola is often covered by a dark or a gangrenous scab, resembles cigarette bun, and considered as the pathognomonic of scrub typhus. Please, you know there are multiple types of scrub typhus, I mean rickettsial infection are there, but this type of eschar is very pathognomonic, very specific of scrub typhus. Now I'll show you multiple pictures again. This is another in the scrotum, how nice eschar is visible, and you will see this is cigarette bun, exactly cigarette bun. There is an ulcerative lesion in the underneath of the scrotum, and this is the another eschar which is mimicking just like a cigarette bun. So this is the black scab which is surrounded by a erythema, and it is going towards the healing stage. So this rickettsia, which is a cocobacilli, this came into the name by Howard Taylor Ricketts, who stayed or who lived 1871 to 1910, and he found out, he was a Mexican pathologist, and he found out the Rocky Mountain spotted fever and this rickettsial disease in US. So that's why he is a pathologist, and he came to know that this adult form and the larval form are the responsible for transmitting this cocobacilli into the human. It is a zoonotic disease. They remain in the rodent population, but sometimes accidental host is man, and that's why once the bite occurs, then only these cocobacilli are released into the circulation. So there occurs eschar and the regional painful lymphadenopathy. And after him, the disease has been, or the bacteria has been nomenclatured as rickettsia. So see this adult form, I mean this is the Chigerborn typhus. So this scrub typhus is a disease which is caused by the bite, not by the adult, but by the trigger. So this is the adult one. This looks like how this looks like. You have a visual field of this. And now if I say this is the larval form, and larval form that bites, not the adult form. This scrub area, why it is known as scrub? Because it is nearer to the habitat that you see many of our houses in the behind. There is a kitchen, I mean the green kitchen or green garden, and we get a lot of bushes and these banana trees and so many. So that's why you get a lot of this type of mites, trombiculid mite. They are wandering there. Wet habitats, that is cultivated land, areas around houses, then edges of dense forest, and moist area. If the swamp is there, then this mite population is not they are visible or they are present. So because of proximity of this dense forest like population in towards us, we get lot of cases of scrub typhus now all over the Southeast Asia. And if you see how they are transmitted, this is the adult. This adult is known as trombiculid mite, and this lay eggs. And this adult trombiculid mite, once it lay eggs, it is being converted to larva, and this larval form is converted to the nymph, and some nymph will be converted to the adult. And this larval form usually bites the rodents, and which are rodents are other reservoirs. And these rodents, again the larva, that is known as trans-ovarian cycle, which continues to the nymph and adult. So this rickettsia, whichever is there here, they are being transmitted into this. So that is a zoonotic disease. But humans at this point of time, some larval form of this adult mite, trombiculid mite, they escape the rodent and coming to in proximity of the human and bite, and they can cause scrub typhus. There is no person-to-person transmission or contamination is there. You can't get a scrub typhus without bite of the larval form. So man-to-man or human-to-human transmission is not there. So what is this scrub typhus? If you say these are the intracellular organism, and you say multiple bacteria, cocobacilli are there, and they are known as Oriensia susugamosi. So caused by intracellular proteobacteria, they are gram-negative in nature, and family Rickettsia. So this first isolated in 1879 in Japan, and first reported in Himachal Pradesh, that is 1934 in India, and its incubation period, I have already told, 7 to 10 days. Now this rickettsial disease, I have already told, they can be of mite, that means trombiculid mite or louse, or you see flea. So these all the tick, either tick bite or trombiculid mite bite, or you say louse bite, or you say flea bite. So there are many these arthropod-borne diseases or vector-borne diseases. The tick flea, louse, and mite. These are the arthropod. They act as in the mediator to transmit this Coccobacilli from the zoonotic population to the human as an accidental host. So classification, Rickettsia can be classified into Rickettsia and Orientia. And Orientia susugamashi, which we are talking of, that is causing scrub typhus. This is a mite-borne disease. And here, Rickettsia prowazhaki, typhi, Rickettsii, Connery, Australia's Siberica, and Akari. These are the group of spotted fever group which are caused by so many. You see, they are caused by, I have already told, either the tick-borne or the mouse-borne or the flea-borne. And we are talking that in India, in Southeast Asia part, we are getting a lot of scrub typhus, and this is ubiquitous. You can get in South America, North America, Mexico, even Africa, everywhere this is present. Now, coming back to this, that Indian scenario, rickettsia is not a disease of India, it is a myth, but mainly of US. No, it is present every part of the world. But in recent times, there has been a surge in number of cases, both from urban and rural area. Spotted fever group is reported from Maharashtra, Karnataka, and Tamil Nadu. We are getting spotted fever group in Odisha, but still then, the most common type of rickettsial infection we come across is your scrub typhus. Scrub typhus is reported from almost all states, that is 28 states, and I can say 8 union territories of India. Everywhere you can get this. And if you go to the geography north, you see north part of Japan and the east part of Russia, and in the below that south, the northern part of Australia, and in the west, if you see the Afghanistan and Pakistan. So this makes the Susugamashi triangle, and this triangle, this belt is famous for this scrub typhus or Susugamashi triangle. So incidence and important vector-borne disease, there are approximately 10 lakh cases each year worldwide, and we know that there are many vector-borne diseases, for an example, mosquito-borne disease, malaria, dengue, so on and so forth, but still then it is undermined disease. So now, after knowing about this disease for last decade, everybody, I mean those who are MBBS or beyond that, they are able to diagnose this by the presentation. So they attack and enter. So once this is there in the lymph node, it will go via the lymphohematogenous route, it will enter into the blood, and in the blood they love the endothelium. I'll tell you, malaria parasite, they go to the, where they go? They go to the RBC. They infect the RBC, they causes hemolysis. But if you say all the other bacteria, they go to the macrophages and neutrophil. But this particular Coccobacilli has a predilection to enter into endothelium, and they causes endothelitis or vasculitis. Macrophage and cardiac myocytes are others they can enter in. And pathogenesis, inoculation, HR is the site of inoculation, invade the local node, and that causes inflammation and multiplication. When the endothelitis will occur, that is known as inflammatory phase. So pathogenesis, bite and bloodstream, diffuse endothelial infections, small and medium vessel vasculitis, microvascular leakage, just like dengue and thrombus formation, you get edema and hypoalbuminemia. So rickettsial vasculitis, you are dealing with the dengue fever, which is very short, 3 plus 3 plus 3. That means in the initial part, that is within 7 days fever, you get a leak. Then it is known as fever, rash, and leak in the within 7 days. Then you think of dengue. But rarely you get hepatosplenomegaly in lymphadenopathy in those cases. But if there are edema or leak and hepatosplenomegaly, lymphadenopathy, you have to bring the scrub typhus or the rickettsial infection as a DD. So course of the disease, first week, systemic symptoms, that is fever, myalgia, and you may get a tender lymph node at the point of entry. Second week is the complications. Already I told, that is the site of a stage of vasculitis, and you can get a cytokine storm at that point of time. Third week is the period of convalescence. So second week is the hallmark, that the inflammatory phase and cytokine storm. Even if cytokine storm, rarely we use IVIG or steroids are indicated. And GIT, vomiting, diarrhea, abdominal pain, kidney, AKI, and CVS, myocarditis and failure we have seen. During the cases of post-COVID, we got 2 types of cases, that is unexplained myocarditis, heart failure. It is due to post-COVID cytokine storm, and sometimes it is associated with this scrub typhus. So acute lung injury, that is pneumonia and non-cardiogenic pulmonary edema, CNS meningoencephalitis, in our case, you have already seen. So when to suspect? So to suspect any febrile child with following clinical features. Classical triad of fever, rash and headache. In a big child, you can get headache. SCR is the diagnostic. So please search for SCR if at all it is there. Lymphadenopathy, yes, because of bacteremia. Edema is a feature because of the capillary leak. Hepatosplenomegaly, loss of sensorium or loss of consciousness stage. It is a CNS scrub. Then comes fever of unknown origin, not responding to usual cell-mediated inhibition antibiotic like cephalosporin and penicillin group. So scrub typhus, you have to suspect in a child who is coming with fever and rash, fever and black ulcer. I have already told SCR, fever and unexplained edema. Usually the fever is more than 7 days, very low grade fever, and the child will not be toxic, but you have to know what it is. It is there. So clinical presentation, that means altered sensorium 24%, lymphadenopathy 24%, RAS 16%, myalgia 12%, seizure 88%, and sometimes we can get bleeding 4% and conjunctival congestion in 4%. So SCR, I have already told, SCR present, that is in our study we have got, this is, I will be talking on our experience with scrub typhus and SCR, 52%, and it is a very wide range, 9% to 52%. Every alternate patient may not have SCR. So coming to another case, Master Dhanush, 2-year male child from Ichapuram. You see the child is hepatosplenomegaly, 7-8 days fever, altered sensorium, and we put our diagnosis again empirically that it could be a scrub typhus. Child required ventilatory support because of cardiorespiratory embarrassment, and same patient after 5 days of doxy treatment. We have not given anything else other than doxy, and IgM scrub was positive. Clinical diagnosis was scrub typhus, and differential diagnosis we made in this type of children: enteric fever, malaria, brucella, TB, and any virus, that is AB or CMV or HIV, dengue fever. Already I told they are famous to have LIC, non-infectious, PID, leukemia, lymphoma, HLH, and vasculitis. So with this note, lab examination is very important. Blood routine, leukopenia, leukocytosis, low platelet is one of the hallmark. Biochemical examination, we have got transaminitis, elevated CRP because of bacterial infection. So investigation, we know that Well-Felix test can be a test, but the test is not famous in Indian scenario. Indirect immunofluorescence test is the gold standard, but still then it is available in few centers of India. So that's why we are not doing this. PCR for Orientia Sisugamusi, that is again, it is very costly. So we are here to know something about Well-Felix reaction. Commonly used screening test, affordable, single titer, more than 1:320 is diagnostic. Now epidemic typhus, you see that epidemic typhus, endemic typhus, OX19, that is Proteus antigen, cross react with this, and OX2, that is this, and tick-borne spotted fever, but in scrub typhus we get OXK. So once we get OXK, so we say that it is scrub typhus, because sometimes we may not get OXK, but if you get OX19 and OX2, so we can say it is epidemic or endemic typhus or a spotted fever. So coming to the gold standard, indirect immunofluorescent antibody assay, test used to detect antibodies in serum. Under a fluorescent microscope, it is expensive, not widely available, though it is gold standard. Another gold standard is indirect immunoperoxidase test. It replaces fluorochrome with peroxidase using a bright field microscope. Staining reaction is positive when you see staining reaction positive when Orientia Sisugamusi particles stain light brown. This is the some bacteria they are seen as light brown, not available in India. So the most important part is ELISA scrub typhus IgM. It is just like ELISA scrub typhus IgM is the diagnostic tool which we have followed all over the country. Rapid diagnosis, widely used, highly sensitive and specific test, and this is the way ICT you see, that is a control is present, and G and M. IgG suggests old infection, IgM and IgG sometimes say it is acute infection. So combining antigen and antibody we have to know, and ICMR say when you tell it is a probable case, because SCHAL, yes, it is definitely defervescence with doxy, it is a clinical response. Lab diagnosis, Well-Felix or ELISA, and suggestive laboratory, that is indirect marker by anemia, thrombocytopenia, transaminitis, all those things, it is a probable case. But once you get this IFA, immunofluorescent antibody test, then only we can say it is a classical case or diagnosed case of SCHAR. But for us, it is the ELISA IgM scrub we are doing. So recommended treatment regimens, drug of choice is doxycycline, 2.2 mg per kg BD, maximum 200 mg per day, and azithromycin, clarithromycin, rifampicin, chloramphenicol. Duration of treatment on an average is 7 days. So treatment doxy-resistant. I have never seen a single case of doxy-resistant. Book says rifampicin and azithromycin is the second line. Pregnancy, you can see chloramphenicol and rifampicin are the drugs. Role of steroids in meningoencephalitis, some group give but no control trial. So that's why routinely we do not use meningoencephalitis cases as steroids. Immunity, multiple serotypes are there, hamper vaccine development. Immunity wanes in 1 to 3 years. So a child who had infected 3 years back can come for again second time scrub infection. So that is possible. So poor prognostic factors like G6PD deficiency, alcoholic liver disease, shorter incubation period, absence of rash, diabetes, delayed treatment, and early MODS that signify that the prognosis is bad. Case fatality rate is 5 to 10%. Early diagnosis is very important to prevent life-threatening complication. Finding of STR almost confirms the diagnosis, and treatment should be instituted then and there. Absence of STR doesn't rule out the possibility of scrub. Even if RDT not available, we have to go with the treatment. So how will you prevent? Prevent and get away from this trabeculid mite. Source of infection is a rat. I have already told they are this trabeculid mite and rat and mite. This cycle is going on in the zoonotic population. Routes of transmission by trabeculid mite, that is the larval form. Personal protection, avoid being bitten by them. Don't go across with your bushy or scrub areas behind your houses. If at all, then you come back and have a nice bath, so that if at all anything anywhere, this larval form trigger bun might has already been attached, that will be taken out. No effective vaccine against scrub typhus as of now is available. So why scrub typhus is emerging now day by day? Because of deforestation, change in climate. Maybe we are more aware of the disease and we are going to diagnose. What is the research in our scenario? Where I am the prime author, scrub typhus, a re-emerging illness in a tertiary care center in southern Odisha. We got 44 cases and we have seen all of them are scrub typhus positive, well Felix positive or negative. They are taken. We got near about 9 to 52% what we have seen the cases of STR. There is another case series of scrub encephalopathy. They presented in a different way, and they all are dramatic response to doxycycline. We have not used azithromycin in scrub encephalopathy because azithromycin is a bacteriostatic drug. It doesn't enter into the blood-brain barrier. So, dear friends, information is there, knowledge is there, application of knowledge in the current practice, for which this IJCP is one of the wonderful platform in Indian scenario to disseminate knowledge amongst all of us. If I know something, then if I say to all of you, then definitely my knowledge will be multiplied to many extent. So this is the current patient which admitted 4-5 days back. You see 14-year girl child, day 1, there is puffiness of face, there is no hepatosplenomegaly, no rash, but the pale is there, thrombocytopenia. We started immediately doxycycline along with ceftriaxone. Then we searched, you see that girl child is having STR here, which is almost invisible. You may miss it. STR search on day 1. So from day 1, we have started doxycycline solo, and ceftriaxone we have stopped on day 2 after getting IgM scrub positive. And you see this is the investigation scrub typhus IgM. This is 2.4 and this is minus 0.1 is negative, and this came out to be positive on day 2. And we have done lumbar puncture. We got 27 nucleated cell. That means protein is elevated sugar, just like pleocytosis. In case of AES or viral, we may get cell up to the tune of 50, and almost all of them are mononuclear. Then day 7, you see how beautifully the child is conscious, and we discharge the child for total 10 days therapy of doxycycline. So this is the experience now. Yesterday, you see discharge, not yesterday, discharge today, and this child is very happy to go home. So if the knowledge is applied and we know that scrub encephalopathy is not uncommon, then definitely we can treat many cases, we can save many lives. So gone those days where any unconscious child, one was AES, that is still existing, one is bacterial meningitis, third was malaria. Now malaria is very less visible. So that's why we have to put each and every unconscious child. Scrub encephalopathy has to be thought of. Each PO child or fever of unknown origin, we have to bring one diagnosis of scrub typhus. So take home message, dear doctors, scrub typhus is very common in our community. all state of India, it is present high index of suspicion in all cases of fever without focus or localizing shine FEO, fever not responding to routine antibiotic like amoxicillin, unexplained fever with rash, swelling, hepatosplenomegaly, lymphadenopathy, loss of sensorium. One has to search for SCHAR. If the SCHAR is not there, then treat empirically with doxycycline, then investigate. You can stop at any point of time if it is not rickettsial infection. Commonly go for IgM scrub. This is available throughout the country. It is very cheap, and drug of choice is doxy or azithro for 7 to 10 days. This is all about. SCHAR search is a must in routine examination of every patient with continued fever. We have to search for SCHAR. So thank you very much. And again, before leaving, I must tell that this case series, I have told that whenever we get a fever of unknown origin or fever without focus, the searching of SCHAR is a must. And whenever you get a neuro infection as a DD, never forget scrub encephalopathy. Empirically, you start doxycycline if the child comes out in a very good way, and the GCS very improved within a short span of time. So definitely you are dealing with a clinically or probable scrub typhus. So with that note, I am handing over. I am stopping here and over to Arpita. And if there are any questions, I am here to answer them. So now it is over to you.
Thank you, sir. Thank you so much for such an impactful presentation. Now, let us see what are the questions that have come from audience. So we'll take maybe not more than 2-3 questions.
Yes, yes.
So the first question is, how can new medical professionals integrate case-based learning into their daily practice?
This is the question actually you people will answer, because you came out how the cases can impact the mindset of pan-India doctors. I'll tell you here, all the doctors who logged in, not necessarily they are pediatric, not necessarily there are a couple of doctors which are practicing with knowledge of MBBS or with knowledge of surgery. They are practicing. They are seeing a good number of child population and adult population as well. So if there is a case-based learning, I have shown you one case, and this has been diagnosed like that, and we have not searched for SCHAR. But finally, once the diagnosis made by the investigation, we have gone back and relocate and re-examine the child, and we got one ulcer. And finally, we told that if the next patient comes, we have to examine in that way. So this is the case-based learning. So initially, if I teach you about scrub typhus, that is not more impactful. But if I will tell you the true cause scenario, and I have shown you near about 15 pictures of the live pictures, how the ulcers of the scrub typhus SCHARs look alike, then definitely if you look in that way, it will have a more impact, and you never forget in your lifetime. If you have not seen a single case of SCHAR, probably the next person comes, your mind will say, let me search for this, and it could be scrub typhus, let me give doxycycline, you can save a life. So in medical science, it is always said that theory is different. Application of theory into the practice is very important, and the best way to learn is by seeing the experience from an experienced doctor, what he has seen. And that's why the case-based learning has a very tremendous impact than your theoretical learning.
Right, sir. Sir, the next question is, what advice would you give to young pediatricians on refining their clinical examination skill for better diagnostic accuracy?
Yes. In 2025, now the reverse approach is there. People, youngsters, they are not examining the patient. They are just asking what has happened, fever for 5 days. So they just, without examination, they write couple of tests, CRP, CBC, urine test, blood culture, but you can't get. And some report will come which is no basis on the clinical scenario. So you have to listen to the history. History is the only way 70% diagnoses are made. Then as per the history, if you say I am having sore throat, I will open your throat by tongue depressal, I will examine the throat. If the throat is red, angry looking, I will tell it is a viral sore throat. You just wait for 2 to 3 days, gargle, paracetamol, that's all. That's all, and you will be cured. So there is no investigation needed. So there is no comparison of anything in medical science that is basic of medical science. One is the proper history taking and detailed examination. If you examine detail, I am sure 90% diagnosis is being made, and only 10% you can get a clue, and you can confirm whether you are right or wrong. If I see a SCHAR, and even if the IgM scrub will negative, I'll not say that it is not scrub. But if it is positive, then definitely I can emphasize, okay, I thought it is scrub and it came out to be positive. For an example, if I see it is a malaria and ICT test positive, then only I can tell it is malaria. But I will not say it is not malaria. I will treat the patient, but I will emphasize that investigation only 5 to 10% diagnosis. But in as of now in 2025 also, so dear young doctors, I will tell, take the proper history, and good examination can tell you that you are the best doctor in the locality. People will like you like anything because no investigation is needed. You can narrow down the investigation, you can focus investigation, then only you can diagnose, and you can give justice to the drug, and unnecessary antibiotic, unnecessary drug will not be provided. So that's why examination and detailed history taking is the hallmark of clinical diagnosis.
Right, sir. Sir, one
Yes,
last
Arpita.
question. Yes. Sir, what are the most
Yes.
common pitfalls clinician face when conducting a detailed examination, and how can they be avoided?
Uh, can you please repeat again?
Yes, sir. Yes, sir. Sir, what are the most common pitfalls clinicians face when conducting a detailed
Yes.
examination, and how can they be avoided?
Okay, okay. Okay. Yes, yes. I'll tell, if you take a proper history. For an example, somebody is telling, I am having pain in the lower abdomen. So you have to examine the genitalia, you have to examine the lower abdomen, then only you know what is happening there. Suppose somebody is having a pain, so I have to examine the ear. You are having sore throat, then I have to examine here. Suppose somebody will tell, I am having pain in the lifting the hand, then I have to examine all the joints on the left side. So that means if you are taking a proper history, you know what are the possibilities, and the examination will be guiding that you are dealing with this type of thing. So proper history will guide you what the things will be done. For an example, I will tell you. Few days back, one of my postgraduate has admitted a case of paraparesis, and he has not examined the back, and he told it is a case of GBS. Now paraparesis, GBS, okay, that's okay. But immediately when I turned the patient and I see there is a big swelling is there in the spine, and big swelling is a gibbous, and that gibbous is due to tuberculosis. So if you do not examine the back, only examine the front because it is a big child, you have not examined the back, so you have missed the bus, and your diagnosis is totally wrong. So for clinical diagnosis, you have to examine front, back, side, everywhere. And if you miss somewhere, then your diagnosis will be totally wrong. So that is one. And many a times we see the proper history taking and the proper examination, we know what the child is suffering from. Many, I will tell you, small kids, they do not speak. Whatever is spoken, that is by the caregiver. Most likely 99% mother. The mother says, my baby is taking my breast milk for last 5 months, but today onwards, my baby is not sucking. So there is something wrong. Why the baby is not taking? Why the baby is crying? Why the baby is febrile? So is it not ear infection? Is it not anywhere something wrong in the mouth cavity of the baby? There are some rashes or there are some ulcers in the mouth of the baby. So you have to examine the mouth. If you don't examine the mouth, then you are wrong. So it means that detailed history, proper examination is highly important for a good doctor. If you are not doing that, then you are bypassing and you are just beating around the bush without knowing the proper diagnosis. For an example, if suppose you are coming to me at your age, doctor, I am having some fever and rigor and chill. Then I'll order dengue test, malaria test, urine test, so many things. That is wrong. I'll just ask you, where are any part of the body is paining? Then only you tell, yes, I am having some sore throat. I know that this bug or this virus has entered through respiratory and it is causing sore throat. Most likely you are having a viral fever. So that is no point of writing urine test. Why should I go for a urine test in when your throat is paining? So that is the answer. So I can avoid that. If by chance the lab will tell there is something wrong in the urine, then I am misguided. You are having sore throat, I am giving urinary tract infection medicine. So that's the reason. So young doctors should take a proper history. At least one patient 5-minute time has to be given. If it is less than 5 minutes, then you are an expert. You are just like a king, or you are just like a, I can say, you are a big doctor of the world. So you can diagnose 1 minute or 2 minutes. So it's not possible. Take a proper history. Give every patient has come to you for a better treatment, and if you do that, then definitely you will be regarded as a good clinician in the community. Not only patient will love you, they will like you, and your medical community will also like you. And definitely if you do that, I think this IJCP platform, you will be telling, okay, oh, in Cuttack, you go to that doctor, and he is very rational, and this is a platform for you can say, I cannot say publicity, but people will learn. So this learning platform is a very good platform. So this much I can say, Arpita. Hello. Asa, asa, asa.
Sorry, sir, just
Huh.
one problem. So that
Hello.
was,
Yes,
yes,
yes.
sir. Yeah. Sir, so that were all the questions for today. And sir, before wrapping up, I would like to thank you for your valuable insights on
You audible. You
understanding.
audible.
Thank you. Thank you so much, sir. Your expertise enriched our
You audible.
understanding. Thank you. Thank you so much for your time and guidance. Thank you. Thank you so much, sir. With this, we are concluding the session for today.
Okay. So,
Yeah.
so thank you, Arpita, for the nice moderation. And I must thank total IGCP Pan India doctors. And I am staying here, waiting for the another session to start with IGCP platform. And there are many other, so many platforms are there. So thanks a lot. Jai Jagannath. Bye
Thank
bye.
you. Thank you, sir. Thank you for your time. Thank you, sir.